This conference will now be recorded.
Good evening, folks. I'm glad that you're here tonight. I appreciate you all coming for class, and we are going to be looking at Chapter 11. But first, we are going to finish up Chapter 10 as far as looking at the coverings of the meninges of the spinal cord. And so what I'd like to do is I'm going to show you my note packet first. This would be under cranial nerve, not cranial nerve, CNS nerves, CNS notes posted just recently, just today there, okay? And so you'll see this term here, it says meninges. Meninges are the coverings, the connective tissue coverings of the structures, the central nervous system structures, the spinal cord and the brain. So what we're going to see is that when we have these meninges, that there are spaces between coverings and outside of coverings. Okay, so let's look at the coverings first. So we have here the dura mater, the arachnoid mater, and the pia mater. Okay, so the pia mater would be having direct contact with the surface of the brain, right? So this is really like a visceral covering that's going to have direct connection to the brain, to the cerebral hemispheres. And in turn, with the spinal cord, would be the spinal cord and spinal cord structures, the inner lining. The outer lining is the dura mater. Tough mother, it's translated, is the outer covering, outer meningeal covering. There are two layers to it. There's endosteal and meningeal layer. Okay? So know that there are two layers. This is the dura is the outer, the pia is the inner, the arachnoid is in between. And the arachnoid, when you think of arachnoid, you think of spiders, right? So web-like connection with the next layer, which would be the pia. Now, we see here as far as the spaces that are either outside of or between the layers. So the epidural space is outside of the dura. So when you have an epidural injection, this is outside of the meninges, outside of the dural covering, the dura mater. You'll see here the subdural space would be, right? So if the epidural is outside of the dura mater, the subdural space is below the dura mater. And so then we have the arachnoid mater, and below that would be what? The subarachnoid space, which is where we have the CSF, the cerebral spinal fluid, flowing through that layer and bathing the CNS structures, the brain and spinal cord. Okay? So very important to know, dura mater, arachnoid, and pia, epidural outside of, subdural below the dura, arachnoid mater, subarachnoid space containing the CSF, below the arachnoid mater. Okay, so let's take a look at go back to the PowerPoint in a moment here. Let's do that as far as, here we go. So the spinal cord, this is chapter 10. And you'll see here, so the continuation of the medulla oblongata, the brainstem, would be what? The spinal cord, right? There are 31 segments, each with a pair of spinal nerves. And we said that you need to know that the spinal nerves are mixed nerves. They carry sensory input and motor output. Okay? Sensory input would be the dorsal roots. Motor output would be the ventral roots. Dorsal is posterior, ventral is anterior. Okay? Protected by these meninges, the dura, the arachnoid, the pia. So the epidural space, the subdural space, subarachnoid space, right? You have to think of them as coverings, and what's between them would be spaces. Okay? And this image here, what you'll see is that it gives you, as far as for the spinal cord, it's showing you the different layers of these meninges. And it's also showing you how we have here's the gray matter, here's the white matter, right? And here we have then dorsal root, so this would be dorsal root input, ventral root output. Spinal nerve is a combination of sensory and motor. We're going to see today that in the cranial nerves, so we have 31 spinal nerves, right? And so with these, and then 12 pairs of cranial nerves, right? So 31 pairs of spinal nerves, 12 pairs of cranial nerves, bilateral, both sides. See it here, bilateral, both sides for the spinal nerves. Spinal nerves are mixed. They contain both sensory and motor. Cranial nerves can have sensory, can have motor, or can have both, right? They're mixed. But we know that spinal nerves are mixed nerves. Okay, so giving you that information there. Go out. And yeah, and so we've talked about the spinal cord as far as what's taking place with that. And let's look now at the spinal nerves. and see, okay, all 31 pairs arise from a union of the dorsal and ventral roots, as I said before. Dorsal is taking sensory input, ventral motor output. Okay? They are mixed nerves, like I said, motor and sensory fibers. Now, this is something that you need to know. So how do we come about of this number, right? So when we're thinking of the spinal nerves, know that above C1 atlas and below C1, so when we're looking at C1, so we have 7 bones, 7 cervical vertebrae, but there are 8 pairs of spinal nerves, 8 pairs of spinal nerves, 12 pairs of thoracic nerves, 5 pairs of lumbar nerves, 5 sacral pairs, and 1 coccygeal tailbone, right? But as far as when we're talking about numbering of the spine, we have 7, 12, that's 19, plus 5 vertebra, that would be 24, 25, 26. Sacrum and coccygeal bones, they are both fused. They are fused. Understood? So that's how we come up with the number 26 as far as the spinal components. But as far as spinal nerves, we're looking at 31. Okay? And all right, good. So that's it as far as chapter 10 is concerned. So let's come back to the notes here. Okay. So again, I please would ask that you would review these notes and rewrite and take notes from them and highlight, please, and review and create cards for them as far as flashcards and such, that you're understanding and knowing the meninges. But now also see here as far as the ventricles. So when we were looking in the lab and we were looking at the sagittal skull model, right, we saw 2 areas in particular. We saw the 3rd ventricle and we saw the 4th ventricle. We saw the cerebral aqueduct, which connects the 3rd ventricle, which contains thalamus and hypothalamus, right, as well as the choroid plexus of the 3rd ventricle, involved in production of cerebral spinal fluid. So these aqueducts, these ventricles, by the way, are spaces that contain the cerebral spinal fluid. Okay? Spaces within the brain that contain the cerebral spinal fluid. They contain these choroid plexuses, which are capillaries, and these ependymal cells. Recall that the ependymal cells, they are involved in working with the capillaries, working with blood in order to produce CSF. Okay? Now, we have here also, which you did not see as far as in the model, but you saw the septum pellucidum. You saw that thin membrane which separates the 2 lateral ventricles. They look like ram's horns, to be honest. So let's take a look at the lateral ventricles. I'm going to come back to that. Here we go. All right. So, okay, this is a good image right here. Let's see if we can get a bigger image. There we go. Okay, so let's save this and I'll share this with you all. Okay. So I'll post this image for you. But see here, what you're looking at here would be, here's the 3rd ventricle. Okay. Here's the 4th ventricle. And what would it be? It would be anterior to the cerebellum, right? And we have that cerebral aqueduct that you're not seeing here because we have these lateral horns. See the lateral horns here and here? Septum pellucidum, right? Kind of connecting in between the ventricles and such. And here we have that 4th ventricle, and you'll see here that the central canal, which passes down the brainstem and into the spinal cord. Okay, so these are the areas where we're containing this cerebral spinal fluid. We're producing it, and it's flowing through, and actually it's flowing around in the subarachnoid space of the coverings of the brain and the brainstem and the spinal cord, which you're not viewing here. Okay, so that's as far as when we're talking about the ventricles are concerned. Okay, so again, the choroid plexus contains those capillaries and the ependymal cells, which are the support cells, the glial cells that are helping to synthesize cerebral spinal fluid. Okay, so you have those terms there and what we talked about already. The cerebral spinal fluid reabsorbed by the arachnoid granulations projected into the veins of the dural sinuses. Now, I would like to show you an image right now of, let's see here, minimize this for a moment. This is, I think this will be a very, and I've posted this image for you all. There we go. Very good. So this is an image, and it's showing you damage that can occur as a result of some type of accident, some type of injury. And what's taking place is that this would be considered a closed head injury, right? Here's the bone. Here's the bone right here in the tan, right? And we're not seeing a fracture in the bone, but we're still seeing damage, and we're still seeing an area of blood that is collecting. This would be called a subdural hematoma, because here we're looking at the dura is the aqua, the dura, that's the outer covering is the aqua, subdural below, so that subdural space, we have an accumulation of venous blood, okay, deoxygenated blood. Now, in the case of a skull fracture as a result of some type of injury, we can have in the epidural space an epidural hematoma, which would be an arterial bleed. You need to know the difference between these two, please, okay? And you'll see here that we have compression of the dura. Both lead to what? Compression of neural tissue, which can lead to tissue death of the neurological tissue of the brain. Here we're seeing the cortex, the gray matter, and the white matter is the inner portion. Gray matter is the outer. The spinal cord, it's different. Spinal cord has white matter on the outer portion and gray matter on the inner portion for the spinal cord. Okay. All right. So let's go back to our notes here. Okay. So here's something that's quite interesting and quite tragic, actually, as far as it's called hydrocephaly or hydrocephalus, right? Pathology in which the production of CSF, cerebrospinal fluid, exceeds reabsorption. An increase in cranial pressure occurs, expanding the unfused skull. This can be quite shocking to see images of. I'll show you an image here. So what's taking place is that, let's see here. Yeah, so this is not, it's not, that's real. That's not anything that's made up. It's quite tragic that these children end up what happens, folks? So we have there's no fusion that's taking place, right? Of the connections in the brain here. Okay, I'm sorry. It is heartbreaking indeed. Yes, it truly is. And so what's taking place, folks, is that the expansion of the skull is taking place with this increase in fluid, and it really is a tragedy. And so what they can do is they can actually, let's see, I want to show you shunting. Yeah, here we go. And so they can shunt to the right right side of the heart. Okay, here we go. There you go. Perfect. So you'll see here, as far as we can shunt to the right atrium, or we can shunt to the peritoneum, okay, from the excess cerebrospinal fluid. Okay, so it doesn't build up. And so the sutures in a child have not fully fused, right? So as such, the skull can expand because the brain needs to grow in a child. So we don't want the sutures to fuse. But in the case of these young children, because the sutures aren't fused, the skull can expand if not addressed and treated. Okay? And it is a tragedy. It's just, it's too sad for words, indeed. It truly is. So what I would like to do now is I would like to go to the cranial nerves. And I'd like to go with the cranial nerves and talk to you about, because this is a very important information as far as discussing the cranial nerves and realizing the pathologies that are associated with these cranial nerves. But you have to know what's going on as far as the function of these cranial nerves. So again, we have 31 pairs of spinal nerves. We have 12 pairs of cranial nerves. Okay? So what I would like to do is I'm going to minimize this first. I'm going to come back here and I would like to show you. So this image here, let's see if I have it posted. Here we go. Okay, and someone had a question. I'm just going to stop sharing for a moment just to see what that is. Oh, yeah, yeah, very sad, very sad. Let me uh, let me share my screen again. Okay, so let me make this a little bit bigger. So these cranial nerves come directly off of the brain. Okay, and so you'll see here this is an old mnemonic that is used in order to, and this is the one that I went to grad school with and learned. You don't have to use this. You can do whatever you'd like as far as understanding this. And I'm going to give you some information also regarding that. And I believe that if I didn't post it, I will post this. I don't think I posted this. So it says, Arnold Olympus, towering tops, a Finn in German viewed some hops. Kind of a weird, mnemonics are always kind of weird and just, but they're quirky, so you remember them. So I've known this for, all these years since I was in um, gross dissection, you know. So you'll see here as far as olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial. Now, cranial nerve number 8, it's better. You see where it says VC? It's more proper name, and it's also known as uh, so auditory and vestibulocochlear nerve. Vestibulocochlear nerve is very, very good because that really helps you to understand that it's two parts, the auditory nerve. And really, vestibulocochlear is the more proper word that we would use term to describe cranial nerve number 8 as far as naming it. Okay. You'll see here also that they are in Roman numerals. We also do that for the cranial nerves. So vestibulocochlear there's two branches. They go to the vestibular portion and the cochlear portion. Cochlear for your sense of hearing, and then vestibular for your sense of balance and equilibrium. Right? Glossopharyngeal, vagus, spinal accessory, and hypoglossal. And so I'm going to talk you through this and know that spinal accessory is also known as just accessory now. But spinal accessory is still applicable, and it helps with this mnemonic, but also known as accessory. Okay. So when we're looking at it here, we're looking at the fact that we have olfactory for your sense of hearing, optic for your sense of vision, oculomotor, trochlear, and also abducens for your ability to move your eyes, right? You have your ability to use skeletal muscle, these extraocular skeletal muscle to move your eyeballs without moving your head. Trigeminal nerve, we're going to see as far as its sensory and motor function. Facial also, facial for your to be able to make facial expressions. These are the muscles of facial expression. Yes, you do. Yes, Kim, you do. Yeah, so you will have to know the Roman numerals that are associated with them, and how I will test you on the testing regarding this for cranial nerves will be that you will have to now know that this is not test 4. Cranial nerves, anything that's in chapter 11 will be on the final exam as new material. Okay, so let me repeat myself. Chapter 11, right? And it's only half of chapter 11. It's not the full chapter 11, but chapter 11, anything to do with the brain and the spine and the cranial nerves, brain and cranial nerves will be new material on the final exam. But I will ask you, many questions will be regarding, I'll say to you, a pathology. A patient has an issue where they're not able to smile and move the facial muscles on the right. Could it be, we're thinking about possible stroke, right? Cerebral vascular accident. We're thinking of also cranial nerves can affect what takes place as far as if the patient was in a car accident and they received quite a jolt and a flexion extension type injury. Could it affect cranial nerves and actually displace them or damage them? That is a possibility. Okay, so I would ask you questions regarding that would make you think along the lines of, well, what cranial nerve is part of this function? And so I tell you something that had an issue with a lack of function. Okay, so let's move on from here. I'll make sure that I post this. Okay, I want to show you this image here. Oh, that's not the same one. I want to show you that cranial nerve image that I posted for you all. And I have too many images here. Olfactory is connected to, did I say hearing? It's a sense of smell. I'm sorry. Did I misspeak for a moment there? Yeah, so olfactory. Okay, yeah, sorry. Yeah, your olfaction for your sense of smell. I apologize if I misspoke. Sorry about that. So let's take a look at this. I'm going to make this larger. So cranial nerve number 1 for your sense of smell. So you'll see here that we have this olfactory bulb right here, and we're going to be penetrating through what would be the cribriform plate of the ethmoid bone. Remember, we've seen this bone, we've seen this area of the bone when we were in lab, as far as removing the calvarium, the skull cap, and we looked at the anterior cranial fossa, and we saw the cribriform plate of the ethmoid bone. This is where we have the olfactory nerve supplies the lining of the nose and relays signals from the olfactory cells that are perceived for your sense of smell. So know that the term olfaction, right? Olfaction would be for your sense of smell. Cranial nerve number 1. Cranial nerve number 2, okay? So we're looking at the optic nerve. So this is for your actual sight, your sense of vision, okay? Sense of vision. And actually, you know what? Excuse me one moment, folks, because I'm trying to just see. I thought that I saved another image. Just give me one moment. Frustrating. I don't see it. Okay. And yeah, here it is. Okay, here it is. This is what I wanted to show you. I'm going to save this also. So I'll share this image with you also, folks, okay? And so what you'll see here is that this gives you also not only just the ability to know the Roman numeral connected with each of these terms, right? And so you'll see here that accessory, instead of spinal accessory, it's just accessory, right? Vestibulocochlear. So I'll share these two images with you here. This shows you also that it's a different mnemonic. Maybe this might help or not, I don't know. But then it also shows you, folks, recall that I said to you that spinal nerves are mixed nerves. They're both. They're sensory and motor. They carry sensory and motor fibers, spinal nerves, 31 pairs. 12 pairs of cranial nerves we have here. So we have sensory, motor, or both, okay? And so you'll see here, and you'll see here as far as, yeah, good. Yeah, vestibulocochlear. So some will say that vestibulocochlear is both. I would tell you that many of the texts keep it just as vestibulocochlear sensory for your sense of balance and equilibrium, as well as for your sense of hearing, okay? Cranial nerve number 8. So you'll see here, we have a mnemonic. Some say marry money, but my brother says big brains matter more. That's one. I mean, there are different mnemonics also that can help you to know, okay, is olfactory is only sensory, optic is only sensory because sense of smell, sense of vision, okay? But then you have here oculomotor, trochlear, and abducens, they're motor, right? Again, because they're controlling eyeball movement, okay? Trigeminal has both sensory and motor, okay? So let's move down here. Let's go back to here. Here we go. Good. So now we're going to move down a little bit to number 3 and see number 3, number 4, and number 6. They're all grouped here on this image. So you see, and you see directly where they're coming off of the brain. Okay, the brain. So right. So you have here cerebellum. You have brainstem here. So this is pons and brainstem. You have here the hemispheres, right? And so you're seeing here, this would be the olfactory. So olfactory bulb, olfactory tract, optic nerve, optic chiasm, optic tracts. We saw that in the lab. I pointed that out to you all, right? So 4, 3, 4, and 6, these are for eyeball movement, extraocular muscles of the eye. So oculomotor, number 3, this controls a lot of movement, folks. Nerve controls movement of the eye and eyelid and changes in the shape of the pupil and the lens. So there's quite a bit of ability that the cranial nerve number 3 has control over. So, but if I said to you that as a result of a car accident, a patient was having issues with the ability to see out of one of their eyes. Could it be that there was damage to the cranial nerve number 2 on the right side or the left, right? So you understand, like, this is kind of like the questions that I would give you regarding you giving me input, as far as that, cranial nerve number 2 is involved in the sense of vision. Understood? Okay. So cranial nerve number 4, trochlear, in conjunction with the oculomotor, right, and the abducens, right, 3 and 6, it also helps controlling movements of the eye. And then abducens also. So all 3 of these cranial nerves involved in eye movement. Okay? Now we get to, so 3, 4, now let's go to 5. So cranial nerve number 5, and you'll see here, okay, good, Michelle. Yeah, so Michelle said that, doing the games on Cengage really helped in order to process and learn this information here, as far as the cranial nerves. So in purple right here, that would be cranial nerve number 5, trigeminal. And on Wednesday, I'm going to give you a little bit more information, but I'm giving you like the basics right now for cranial nerves. I'm going to give you a little bit more information regarding cranial nerves next class, okay? So cranial nerve number 5 controls muscles involved in chewing. So we would say the muscles of mastication, the ability to chew. You see masseter right here, masseter, pterygoids and such, these are all involved in the ability to chew. Cranial nerve number 5, that's the motor aspect. Then sensory input, right? So relays sensory information from the eye, teeth, and the side of the face. So you see here that there are actually, it's called trigeminal because there are 3 branches of the trigeminal nerve. And so have you ever heard of someone suffering from something called tic douloureux or trigeminal neuralgia? This is a pain that is extremely painful, facial pain, and sometimes it's not really understood or known why the patient is experiencing this type of pain. Yeah, Jen, it's really it's a terrible type of pain. Yes, horrible. Yeah, understood. I've had patients with trigeminal neuralgia at different levels, and it's one of those pains where, sadly, it can be so bad that patients want to commit suicide as a result of the depth of pain that they experience as a result of this. Also know that blood vessels can also cause some type of compression upon one of the branches of the trigeminal nerve, and this can also lead to that very painful presentation. So that's trigeminal nerve, cranial nerve number 5. Now, cranial nerve number 6 we saw was the abducens. So cranial nerve number 7, we're going to move down here, the facial nerve. Now, have you ever heard of someone experiencing something called Bell's palsy? So Bell's palsy can have a presentation very similar to a cerebral vascular accident, a stroke. What can happen is that one side of their face, okay, Michelle, and how is your brother doing, Michelle? You can speak out loud if you'd like, please.
Yeah, he had it a couple of years back from an infection, a really bad infection in his tooth.
Yes.
And his one side of his face just drooped. And it's gotten better, but he still has like kind of a sag on his eye and the corner of his mouth.
Thank you for sharing. Yeah, so this is something that Bell's palsy, it can be as a result of the etiology, can be as a result of some type of bacterial viral infection, and it can cause issues where one side of the face, the musculature, right, because facial nerve is motor to the muscles of the face, of facial expression, this can be an issue. And so, okay, thank you, Jasmine. Yeah, so most oftentimes after, months to a year, pretty much it can be very close to being 100%, but some people do end up having some residual type of issues where the part of their face is just not, the musculature is not doing, physical therapy can help with that, okay? So how about George Clooney was one, he's somebody who experienced Bell's palsy. Okay? Also, your sense of taste. Okay, your sense of taste, cranial nerve number 7. Okay, the anterior 2/3 of the tongue. Now let's go to cranial nerve number 8 over here to the right side of our screen, and we'll see here. So right here in blue, this would be for the vestibulocochlear nerve. So the auditory nerve, it's also known as the acoustic nerve, right? So auditory, acoustic, vestibulocochlear is the best name that we use now because it really gives us the presentation of both branches of cranial nerve number 8 for your sense of hearing and your sense of balance and equilibrium via these semicircular canals and the vestibular apparatus through there. And we'll talk about that next semester. Cranial nerve number 9, glossopharyngeal. So cranial nerve number 9 here, you're seeing nerve controls the salivary glands, relays sensory signals from the tongue and the pharynx. So also we're looking at cranial nerve number 9 for your sense of taste and the posterior aspect of the tongue, okay? Then we go to cranial nerve number 10, 10 is down below here, there we go. The vagus nerve, okay? Vagus nerve has very important nerve, and this nerve controls the muscles and glands and many of the internal organs, including the heart, the lungs, and the stomach. And so what goes on as far as sympathetic and parasympathetic information traveling as a result of, well, parasympathetic information, and traveling as a result of the vagus nerve. And if a patient has a spinal cord injury and there is damage to the cord and the patient is a quadriplegic, if the cranial nerve number 10 is still intact, they can still have nervous system input to the organs of the body, and they can still be functioning via that neural stimulation of cranial nerve number 10, even though the cord itself has been damaged and can affect what goes on as far as control of the upper and lower extremities. Cranial nerve number 10, very important nerve. Cranial nerve number 11, the accessory nerve, or aka the spinal accessory nerve. It's going to control sternocleidomastoid and the trapezius muscle, okay? And so it's just a motor nerve involved in also controls muscles involved in swallowing and moving the head. So sternocleidomastoid would be rotation and flexion, and then the trapezius would be for the ability to move your shoulders, elevation of the shoulders, also working with the levator scapulae. Cranial nerve number 12, last cranial nerve, so hypoglossal nerve. So this is a nerve that controls the actual skeletal muscle of the tongue. The tongue is a skeletal muscle, you have conscious control over it, and you're able to move it in different directions and such, and allow for you to be able to produce speech, phonation, P-H-O-N-A-T-I-O-N, phonation. All right, so that's the cranial nerves, folks. And so I highly recommend, I'm going to provide a little bit more information on Wednesday to help you with these, but I've given you a good amount right now. And I'm also going to go to, let's see here, this is, I'm going to go to, yeah, there we go, chapter 11. And I've only given you a portion of chapter 11, like I said, not giving you the whole PowerPoint. And what I'm going to do is I'm going to show you, here we go, the last portion of the PowerPoint here. And so you'll see here, as far as the 12 cranial nerves and their functions, we have here, this just gives you a few quick slides, giving you just, so thinking of olfactory for smell, optic for sight, for vision, oculomotor for the movement of the eyeball, cranial nerve number 4, also movement of the eye, cranial nerve number 6, abducens, movement of the eye, 5, trigeminal, so the ability, muscles of mastication, the ability to chew, as well as sensory input from the 3 areas, because it's trigeminal, 3, so from 3 branches of the trigeminal nerve. Cranial nerve number 7 for the facial expression, muscles of facial expression, as well as sense of taste and control of tear and salivary glands. So this would be lacrimal glands, tear production, salivary glands for saliva, vestibulocochlear, again, for balance and equilibrium, as well as hearing. 9 would be for glossopharyngeal, for swallowing, for the salivary glands, as well as the sense of taste in the posterior aspect of the tongue. Cranial nerve number 10 for sensory and motor input, and really control of the thoracic and abdominal pelvic organs, viscera. Cranial nerve number 11, accessory, for aka the spinal accessory, for swallowing as well as for head movement and shoulder movement. And then hypoglossal as far as movement of the tongue. So if a patient is having issues speaking, can one aspect of the differential diagnosis be to determine whether they've had damage to cranial nerve number 12? Okay. And let's go back to, all right, I'm going to go back to my notes here. So we've looked at meninges, we looked at ventricles. Okay. Let me talk about this a little bit here, and I'm going to talk about the cerebral hemispheres and looking at an image of on the PowerPoint of the cerebral hemispheres and just reviewing with you the lobes and such. Okay, so plasticity. This is a very important, should be understanding regarding the ability for the brain to change and adapt as a result of experience, and also as a result of, for a young brain to have experienced some type of trauma and damage and still be able to then, because of plasticity, other areas of the brain can take over for the damaged areas. Okay, so look at this here, read this here. So the healthy brain continues to, 1, create new neural pathways, 2, alter existing ones as a result of new experiences that we're going through, 3, learn new information, and 4, create new memories. Just start typing here to bring features to you. Oh, I don't. Okay. Yeah, so very important for you to see that a healthy brain has this ability to create memories, to memorize things, to learn new things. And it's as a result of this plasticity. And know that there are conditions, like in the case of Rasmussen's syndrome, where a patient can have a portion of their brain that is firing when it shouldn't be, and creating areas of issues where a patient is going through seizures. This is a young child, and they're able to, as a result of treatment, because medication won't stop this type of seizures that a patient is experiencing, that it's a young child, they're able to remove a cerebral hemisphere, and the other hemisphere that's left will take control for that's missing. And because of plasticity, and because the brain is young enough, it will be able to adapt and to take over for the tasks, the functions that the missing hemisphere was in charge of. Pretty wild stuff, folks. So plasticity is amazing, that we have this ability to learn and to adapt. You'll see here, as far as the cerebrum, right? Cerebral hemispheres. These are paired, right? They're bilateral. We have the gyri and the sulci, or a gyrus is one, a sulcus is one. As far as the grooves, the indentations, and the ridges, the folds would be a gyrus. So we saw in the lab there, as far as on the sagittal head, and as well as the actual model of the full brain, we have the cortex, we have that's the outer portion, and we have the white matter, which is the inner portion. Notice that as far as this won't be in the lab, but basal nuclei, these are pockets of gray matter. So know that gray matter for the brain, outer, white matter, inner, but spread throughout the white matter will be basal nuclei, these pockets of gray matter. Okay? The corpus callosum, we saw that in the lab, and we saw that that's the area which will connect the two cerebral hemispheres. That will allow for communication between the two, and actually a crossing over of fibers and such of information from one side to the other, so that, and you all know this, I'm sure, but I'll remind you of this, that the right cerebral hemisphere will control the left side of the body. The left cerebral hemisphere will control the right side of the body, right? And that corpus callosum allows for, there's a crossing over of information and fibers. So the lobes here, now you'll see here that, so, oh, what is this? The insula, or the insular lobe. We know about the frontal, parietal, occipital, and temporal, and we'll look at an image of that in just a moment. But the insular lobe, well, this is located deep within the lateral sulcus, right? And this has a strong correlation with addiction. And so that if the insula has been damaged as a result of surgery or as a result of some type of traumatic injury, it seems that the insula has some type of role in the actual then alleviation of the addiction. So in particular, it was observed as a result of brain surgery that patients who had a tumor or had to have, part of the material of the brain in the insular lobe removed, a patient who was addicted to cigarettes and would smoke multiple packs per day, after the surgery had no desire to smoke cigarettes. Quite interesting. So that's quite fascinating. So what I'd like to do now would be to show you, let's look at some images in the PowerPoint.
Dr. Perrone, does
Yeah,
that
go
have
for it.
anything to do with if somebody gets a concussion? Would that be what gets injured for that as well?
Well, I would tell you that with a concussion is not as severe a traumatic injury. Okay, yes, it's a traumatic injury to the brain, but it's not as severe as something. Let me show you as far as in my notes here. Excuse me, one moment. Here we go. I wanted to show you this here. So in the case of concussion, slight brain injury, contusions, edema, right, present within the brain, these are more severe damage to the brain and can cause actual damage and death of tissue, right? So as far as concussion, although it's considered a slight brain injury, remember that the damage is cumulative. And so people who are involved in sports that can lead to concussions and multiple concussions can lead to a cumulative effect of damage to the brain. But so I would tell you that more contusions and edema and multiple concussions, then they can lead to damage. But really, like the insula, primarily it's really as a result of more of like a tumor issue and surgical intervention and removal of that area, because it's a little bit more deeper, that lobe. Okay, you actually have to move temporal lobe and the frontal lobe to actually view the insular lobe. Let's show you an image of that. You're welcome, Jen. Yeah, so see this image right here? So see how we've moved frontal, temporal, and we're viewing deep within the insular lobe. Here we go again. Here's the insula. So we're moving temporal, moving frontal, a little bit parietal, and we're actually being able to view the insular cortex. You can see it here as we remove tissue and such. So this is a very important area as far as, like I said, this correlation, and they're still doing studies regarding addiction and the insula. So it'll be interesting to see down the road what information we're able to gather from that and how we might be able to help folks with addictive behavior and such. And maybe as a result of some type of laser surgery or some type of whatever, maybe radiation, I don't know, but that can cause maybe slight damage to the area that can affect the desires of the addictive behavior. I don't know, but we'll see down the road. So here we have, let's go to, yeah, let's look at this image first. So as we're looking at this image here, so we can view here frontal lobe, parietal lobe, occipital, temporal, cerebellum. We have pons and the midbrain, so the cerebral peduncles, pons and medulla oblongata. Let's go to here with this image here in the PowerPoint. This is chapter 11. We're seeing the gray matter is the cortical matter of the brain, of the cerebral hemispheres, and it's the outer, and the white matter is the inner. We're seeing here that at the corpus callosum, we're allowing for these fibers from both cerebral hemispheres to cross over, right? And we're seeing here a gyrus and a sulcus. And I would like to go back to, here we go. Let's look at this here. This is a good image. This is in the, again, the PowerPoint here. And what we're seeing here is that we've talked about as far as the visual cortex, occipital lobe, the hearing cortex, the auditory cortex, the temporal lobe. Look at the ability for speech would be here and also more like here. Here we're looking at, so recall the central sulcus, and the precentral gyrus, the postcentral gyrus. This would be for what? This would be for motor, the motor cortex, the sensory cortex. Okay, and we'll see here that there are other areas, and I'll share some other images with you regarding that there are association areas that will help and enable the ability for your sense of motor control and your sense of sensory input. So motor output within this whole, like frontal lobe is a big part of that, would be for motor control, as well as for your cognitive ability, your ability to think and process information. Sensory input is we're receiving information from sensory receptors, and then we also then, and it's passing through, by the way, it's passing through in order to get here, other than your sense of smell, it passes through the thalamus present within third ventricle. Okay. Let's see here. Yeah, so let's, I think that's it for today that I want to go over. I think I've given you a lot of information today, and let's go here.